Okay, so let's continue our discussion about SIADH and diabetes insipidus. So when we're talking about the endocrine system, with these two disease processes or disorders, we're talking about the pituitary gland and the posterior pituitary gland, not the anterior. And what you need to know is that it's the hypothalamus, which is above the pituitary gland, is actually what produces ADH, the antidiuretic hormone. And the posterior pituitary actually stores and secretes the ADH when needed. So we can have problems with our hypothalamus, we can have problems with our pituitary to cause an imbalance between the ADH on whether it is it's secreted too much or if it's secreted too little. There's many disease processes that can cause this, and brain trauma and medications. So the antidiuretic hormone regulates the amount of water in our body. So if it's off kilter at all, it can increase our fluid volume or it can decrease our fluid volume. ADH also constricts the blood vessels. That's how it's caused. So it constricts blood vessels, which cause the renal tubules to retain water. And it's a very tricky balance. So if ADH causes us to retain water, we can then say that if we have too much ADH, right here, we have too much ADH, then our kidneys retain fluid because of these renal tubules, and we have fluid retention. And remember, let's go back here again. If ADH constricts blood vessels and cause water retention, then if we have too little, so the opposite, ADH, then our kidneys do not reabsorb water, and then we get fluid excretion. So they are the opposite of each other. So this is the little picture that was in the PowerPoints. So with SIADH right here, we have an increase of ADH. We have too much antidiuretic hormone. So now we have fluid retention. Okay, and I'm going to go through these one at a time, one side at a time. So we're going to talk about SIADH. So we have too much ADH and we have fluid retention. So if we have fluid retention, that means we're going to build up all of this fluid within our body. Think of a big puffy man or a big puffy lady full of fluid. Okay, so we're going to get hypervolemia. That's going to, if we have hypervolemia, that's going to increase our blood pressure, right? Because of that fluid excess. It's going to dilute our sodium. So we have more water in our body than we have sodium. We actually have the same amount of sodium, the normal amount that we have, but it's diluted. So it's going to give us the same side effects as if we had hyponatremia, because it's going to dilute our blood as well. Okay. So we're going to have hyponatremia because it's diluted. So we have to watch out for those neuro symptoms. Remember when we talked about hyponatremia? With this, we have an increase of fluid retention, but we also have low urine output because it's an antidiuretic hormone. So it doesn't, we haven't too much of it, so it doesn't want to diurese. It's going to hold everything in. So your urine is going to become concentrated. That is called high urine specific gravity. Okay. So you got this big puffy guy, hypervolemia, high blood pressure, all because of the hypervolemia. We have dilutional hyponatremia, so we have low sodium. So we really have to watch those sodium levels because of the neuro and the seizures that can happen. We have low urine output, very low. It might even be zero, okay? And we have high urine specific gravity. So if you do have some urine, it's going to be very, very concentrated because there's no fluid going through that kidney and those nephrons, okay? So what do we do for SIADH? So we can do a couple of things, and this is kind of crossing over a little bit into med-surg, but we are going to stop fluids, because if we have too many fluids, remember fluid retention, we don't want to give them any more fluids. It's not going to help because they're not urinating any of it out, and so we're just making matters worse. We're going to dilute it more. So we're going to do stop the fluids, so no normal saline, fluid restrictions, okay? Just like that CHF person. And this patient kind of looks like the CHF person, except CHF, you're going to have, you know, big puffy ankles, but with this SIADH patient, you're going to have edema everywhere, okay? So we're going to stop the fluids or give fluid restrictions. We're going to give loop diuretics. Okay, so we want to get those kidneys working. So we're going to give loop diuretics to promote diuresis. Okay, right now, if their sodium is low, we have to monitor their electrolytes if we're going to give them loop diuretics, and we especially need to monitor that potassium, because as we know, a loop diuretic is potassium thrower away. Okay, leaves our body, so we need to really monitor that. We want to replace the sodium very slowly, and however we do that is going to have a restriction of increasing the sodium value by 12 millimoles of liter in 24 hours. Okay. Now they might give hypertonic solution, that 3%, remember? So remember we talked about albumin before? So they could give 3% normal saline in this case. So if they did, it would go in very slowly. But remember, it's hypertonic. So if the fluid that we're giving them into their veins is hypertonic, then the fluid from their edema, from their interstitial spaces, is going to come into their vascular space. Then we're going to give them the loop diuretics to diurese all of that fluid out. This patient that we're discussing is definitely in the ICU because of the fluid changes and the risk for cerebral edema, and the electrolyte changes could be too quickly. So this is very, very important that we make sure that we have orders from the doctor, even if they're not in the ICU and they're not getting 3%. Get orders for the doctor. Make sure that you have orders that they need to check that sodium value every 3 to 6 hours. Another medication that we spoke about is a tetracycline type antibiotic called declamycin, and it just kind of has a secondary effect where it can inhibit the ADH. So remember, we have too much ADH in SIADH. So this inhibits ADH, and it also helps promote diuresis. Okay, so we can give them loop diuretics, give them some hypertonic solution. They might even decide to give them some albumin, declamycin as well, or if they have a mild case, and then replace the sodium. Okay, so big puffy guy, fluid overload, high blood pressure, monitor urine changes, all because there was some problem with the hypothalamus or the posterior pituitary, or brain damage of some sort, maybe a trauma, medications, lots of things can trigger this. Okay. So we just talked about too much ADH, antidiuretic hormone. So now we're going to talk about too little, and the causes are similar. Okay, any type of damage. And of course, whenever we're talking about all of these illnesses, we always want to treat the cause first. So these are a lot of times therapies that we do before we find out what the cause is, just to keep the patient alive. Okay, so let's just refresh now as we go through diabetes insipidus, not related to the diabetes mellitus that you know about. Okay. So with diabetes insipidus, we have too little ADH. So remember, ADH constricts blood vessels, causing us to retain water. So if we have too little ADH, then our kidneys do not reabsorb water, and we have fluid excretion. Okay, so we have fluid excretion. So if we have too much fluid excretion and we're urinating out a lot, and I mean a lot, that is called polyuria. So there are some similarities. So polyuria is 2 to 24 liters of fluid loss in 24 hours. So think about that, 2 to 24 liters. This patient is completely dehydrated. Because they're dehydrated, they're going to have very low blood pressure. They're concentrated because of the dehydration, so they're going to have hypernatremia. And their urine, though, is going to have low specific gravity because so much of the fluid is coming out of their urine that it's dilute. Okay, so they're going to have low specific gravity because of the sheer volume, only because of the sheer volume. Okay, so too little antidiuretic hormone, fluid excretion, polyuria, dehydrated, low blood pressure, hypernatremia. Okay, so one of the ways that we can fix this is by giving something called DDAVP, which is a synthetic antidiuretic hormone, otherwise known as desmopressin or vasopressin. So another name for antidiuretic hormone, ADH, is vasopressin. These are the same thing. ADH, vasopressin. So desmopressin is a synthetic form of that. And what desmopressin does, if it's synthetic ADH, what does ADH do? Remember, ADH constricts blood vessels, causing us to retain water. So if we give it synthetically, it's going to decrease our urine output because it's retaining fluid. And it's going to increase our blood pressure, which is good because we have low blood pressure. So it's going to decrease our urine output so we can hold on to that fluid a little bit, and it's going to increase our blood pressure. This medication, though, can decrease sodium levels too fast. Okay, so we can cause, by either end of the spectrum, we can bounce back and forth to SIADH and diabetes insipidus if we overtreat. So this is an easy way that we can overtreat is by giving too much desmopressin, causing fluid retention, increasing blood pressure, diluting the sodium. Okay, so that's causing the sodium to decrease in value and too fast, and then we're going to have neuro changes. Okay, so vasopressin can technically cause SIADH, and declamycin, which is the treatment for SIADH, can technically cause diabetes insipidus. Okay, think about all of the basics. Think about them as opposite of each other, and you should do fine. Okay, remember the basic patho here. Very basic: hypothalamus, pituitary, posterior pituitary, and basically what happens when we have too much ADH and what happens when we have too little ADH. Okay, all right. I'll talk to you later. Hope that helped.